Welcome to this evening's panel discussion on nutrition and HIV. I'm Jill LaFawn, and I'm the director of Project FIND, which are psychosocial support services for people with HIV and AIDS here in Monroe County. It's my pleasure to introduce our panelists this evening. Starting to my immediate right, we have Robin Black. Robin is a graduate of Ball State University with a bachelor's degree in nursing. She works on the infectious disease floor at St. Vincent's Hospital in Indianapolis, and she's been there for 8 years. She also works on a part-time basis for Caremark. Next to Robin is Diane Miller, and she is a dietitian from Caremark. She's been there for 9 years and working with an HIV population for the last 5 years. Next to Diane is Barb Murray. You want to look? I knew. Barb Murray, and Barb Murray is an inpatient dietitian with Bloomington Hospital. Next to Barb is Marcia Profit. Marcia is a medical nutritional representative from Ross Laboratories. She's been working with Ross for just over a year and works primarily with hospitals and outpatient clinics. We'll also be joined shortly by Lori Trudeau, who is an outpatient dietitian at Bloomington Hospital, who has an undergraduate degree in dietetics and a master's in health promotion. Before I turn it over to the panelists, I want to acknowledge the person who is primarily responsible for putting this together this evening, Tina Harnett. I want to recognize all the effort that Tina has put together in pulling this together, and just want to say how much I appreciate it. So now we'll proceed with the panelists. We've asked the panelists to each give a brief overview of what they see as a primary focus point for nutrition and HIV. And did you draw lots to see who would start?
No.
We'll let Marcia start.
Okay. Closer to the microphone here. Like I said, I'm with Ross Laboratories, and one thing that Ross has done is take an initiative to provide a nutritional supplement specifically designed for the HIV/AIDS population. It's currently the only nutritional supplement out on the market at this point. What you might find over here is some Advera, and that is the name of the product. We have some recipe books which cover a wide varieties as far as nutrition and HIV with the disease, and it covers all aspects of what you need to look for as far as eating to maintain your nutritional status, in addition to food safety and just different recipes of the product. So you can try the chocolate banana whip over here to the right. We also have some coupons as well, and in addition to, we have some newsletters that come out giving you updates as far as nutrition and HIV and how to maintain a healthy status. As you're all aware, nutrition plays a major impact in the progression of the disease, and any way that we can hinder that from happening will definitely make the quality of life much better for the patients. I'll go ahead and handle this to Barb.
Okay. Can you hear out there? Okay. One of the things I'd like to mention is that as a dietitian who works in the hospital, I often see patients at more of the end stage. And so my words of advice, I guess, tonight would be, it's real important, I think, for to prevent weight loss right from the beginning. I think it's real important for people to monitor their weight very closely, and if there's any weight loss, to deal with it right away, because what studies are finding is that oftentimes as people lose weight, and then if they have kind of a setback, an infection, they lose a little more weight, oftentimes they don't regain it. So there's a kind of a gradual progression of weight loss. And so I think it's a real key is to make sure the weight is monitored and that weight loss is prevented way up front and not worrying about it way more at the end. The other thing we'll probably talk a lot more about tonight too is the importance of food safety. And I think over the years, people have kind of gotten a little lax about food safety, and people kind of forget about things that they might have heard from their mothers or grandmothers or whatever. And I think that's real important, and there's a reemergence of the importance of food safety and not taking your food for granted, because it, as you probably have all heard about some of the outbreaks of E. coli and different things in hamburger and salmonella and eggs. It's real important to take your food very seriously and to use some real good common sense things with food safety. So those are the two areas I think are real important, and we can elaborate on those later on.
Did somebody have a hand up back here? Oh, okay. I'll make sure that we do that. My name is Diane Miller. I'm a registered dietitian, and I work with a home infusion company called Caremark. If you're not familiar with what home infusion is, it's something that's kind of really cropped up here in the last 10 years, secondary to DRGs. I don't know if anybody's familiar in here with what DRGs are. These are something that our government requested that we start doing in the mid-'80s. We were getting patients out of hospitals quicker, and many patients were still fairly sick and really needed some fairly intense care, and home care companies kind of arose out of that need. I have worked in home infusion for the last 5 years. I've been a dietitian for almost 10 years now. I can remember the very first time that I ever heard about HIV. I was in my sophomore year of college, and I was attending a pharmacy class with my twin sister at Purdue University. And it was in December, and I can remember this professor being just very distressed about a journal article out of the New England Medical Journal. And he was discussing this bizarre new virus that was occurring in male homosexual population in New York City. And they could not really figure out exactly what this virus was. And it came to pass after the end of 3 years that we found out this was the HIV virus. In the last 10 years, I think that we have had lots of things happen with this particular virus, primarily the stigma. And I think that that took a primary role in the forefront. And I think some of the medical issues were not addressed as closely, and specifically nutrition being one of those, because we had all kinds of social implications with the HIV virus. But I think in the last 10 years, we've come a long way. We have means of treating specific opportunistic infections. And I don't know, are you familiar with that nomenclature, opportunistic infection? Yes? No? No. You don't know what I'm talking about. HIV is the virus that causes AIDS. People are usually exposed to it by blood or body fluids, etc. So that's something that people know. Opportunistic infections are the secondary diseases that arise as a person's immune system begins to collapse. And the immune system begins to collapse after they are infected with the HIV virus. The opportunistic infections, I sound like I'm on like very bizarre method here, but the opportunistic infections are some of the secondary diseases, and there are some real nutritional implications. And as I was saying before, in the last 10 years, we have become able to take care of one particular disease. Pneumocystis was a type of pneumonia, and people 10 years ago, when you would come into the hospital with pneumocystis, it was not sure whether or not you would live to walk out of the hospital. And now we have effective means of preventing pneumocystis, and people take prophylactic treatments. I think that we have had a lot of emphasis in the last 10 years on some of these prevention means, and we have HIV patients who are newly diagnosed with HIV, who live a long time with the HIV virus and are very healthy. And I think maybe part of that is because we have earlier means of detection. But I think that nutrition is going to play a larger role as people are beginning to be looked at with HIV as not having an illness that they die very quickly from, but having rather a chronic illness. And I think nutrition, as in any other area in our life, is going to be shown to play a real factor. As Marcia mentioned, there are some disease-specific products that are being brought onto the market. The Advera that they're using has some specific formulations that seem to work out very well for the HIV population. And I think that we're going to find with this particular population, as we see the wasting occur all the time, or primarily with the number of patients, that we're able to prevent that in some cases. I think that, as I'm sure that maybe my colleagues up here can vouch for the fact that we do have patients that do continue to waste, and there are some bizarre mechanisms that are going on nutritionally, some metabolic pathways that are very messed up, that we really don't understand why a patient wastes. But I think that in the next few years, we are going to get more and more information on specific metabolic reasons why the body is wasting, and we're going to be able to sit down and take some real aggressive nutrition intervention. So I would hope that you would keep your ear to the ground, the people that are interested in these types of therapies that are undergoing. And I think that this type of work that is being done in the area of HIV, because of wasting, we cannot starve people to sit down and conduct research. We're going to be able to sit down and correlate some of our HIV research to other areas, for instance, with our cancer populations. So I think it's going to be some very positive work that we will see coming out of our HIV populations. And I'm going to roll it on down.
Hi, I'm Robin Black, and hopefully this evening I can give you a nursing perspective. I've been a nurse for 8 years, and most of that 8 years has been taking care of HIV/AIDS related patients, both young and old. And I just want to stress this evening that it's a multidisciplinary approach, and in that 8 years' time, I've relied on these dietitians so much of the time, and it's real important to look at malnutrition and diarrhea and all the things that go along with that as a team approach. And so hopefully you guys will ask a lot of questions, and I hope that if not myself, everyone up here can answer them for you.
Do I need to speak? Okay. Hi, I'm Lori Trudeau. Basically, I work with outpatient services at Bloomington Hospital and haven't had a lot of exposure with patients coming in that have been just recently diagnosed with HIV. I think we're going to see more of that, though. I think the need is going to be out there for education so that people can do what they can to prevent themselves from getting into a lot of trouble early on by educating themselves about their diet. And I think that's where our role will come in the outpatient area, is catching people before they actually get into some full-blown problems and teaching them the correct way to eat and how to supplement their diet with high-protein foods and high-calorie things. And at the same time, maybe work on preventing some problems with their gut. It turns out that the research is starting to show now that the gut is involved in full-blown AIDS quite a bit, where the problems that are occurring with the malnutrition have an effect on the malabsorption of nutrients. And so this is causing a lot more problems for people. But I think if they have a little bit more information in the beginning as far as how to best treat themselves and to continue to follow up with the staff, say with the nursing and their healthcare team, I think they'll be in a lot better shape in order to prevent some serious problems early on.
We can move on to questions. Right. So basically, what you guys are saying is that most of these HIV patients, one of the major factors in how the virus turns into AIDS is strictly, mainly towards nutrition, how they intake.
I'll sit down and speak to that briefly. The virus is not affected by nutritional status per se. Once a person is infected, they will more than likely progress to full-blown AIDS. And what that term, if you're not familiar with the distinction between HIV positive, a person can be HIV positive and asymptomatic. An example that I would give you would be Magic Johnson. I mean, this is an individual who is a very healthy individual. He has the HIV virus. He is infected. He will probably progress as his immune system deteriorates to full-blown AIDS. When you are diagnosed with being full-blown AIDS, there are a number of criteria that the CDC have for being diagnosed as being a full-blown AIDS patient. One of those is weight loss and nutrition. And if an individual loses, say, 15% of their body weight, they can be diagnosed as a full-blown AIDS patient. If an individual becomes sick with an opportunistic infection, and these are the infections that result secondary to having the HIV virus kind of collapses the immune system, and you are able to get every infection known to man and God. So, an individual who has, say, an opportunistic infection like pneumocystis, can certainly, utilize having some good nutrition standing to kind of help them through that sickness. Now, the point that you're getting to with the nutrition, how does that play a factor in there? individuals that live in third world countries that have poor nutritional status, like the Rwanda type situation. They had all the cholera here. Do you remember seeing that this summer? Saw these horrible pictures of infants and mothers, with cholera. Many of those individuals were malnourished. Individuals that are malnourished can become sick and easier. I don't know if anybody in here has had like mono, or you've had flu or a cold. If your nutrition status is poor, you may be more prone to infections. I've seen people who have low body weight who have been very prone to being sick. Maybe the nutritional status isn't where it needs to be. Certainly also patients who have chronic illnesses or who have diseases like cancer, if they are not well nourished during the time that they are being treated for, say, a cancer treatment, they may not withstand the radiation or the chemo. And the point with the nutrition and the HIV is that if you are HIV positive, you need to maintain your nutritional status to the utmost effect, as long as you can, so that you're not exposed to some of the infections that you might, normally be to, an individual would be on a day-to-day basis. Do you see what I'm saying?
Can I add to that?
Mm-hmm.
I'd just like to add a little bit to that, and some of the research is starting to show that even though people may not be diagnosed with AIDS, there is, during the HIV infection, a very, very gradual loss of lean body mass. And it's not something that you see and that you would notice right away, but they are starting to think that some of the lean body mass is being lost earlier on. And so that's why we encourage, and as Lori had mentioned, that we really want to make sure people are aware of their eating habits and nutrition right up front so that we can prevent the loss of lean body mass. With HIV, they are finding that oftentimes it's not that people lose fat as readily as they start losing lean body mass. And as Diane was saying, there's some metabolic pathways that we don't understand. What happens? Why are these people losing lean body mass rather than fat sometimes? And so there's still a lot of study going on, but we do encourage people to eat well right from the beginning to prevent that weight loss, because as I said, as the opportunistic infections come up, people tend to lose weight, and oftentimes they don't regain back to where they were, even though they've gained some. Frequently they don't gain it all back, and if you do that a couple times, at some point you've lost quite a bit of lean body mass. So that's another way that nutrition plays into that.
I work with pediatric infectious disease specialists here in Indiana, and one of the problems that we ran into with our pediatric AIDS patients was that they just didn't have the money to buy, supplements and things like that. And I was just wondering if the pharmaceutical corporations are working with the government on more funding for AIDS patients as far as buying Advera and things like that.
That's definitely a concern. What was asked is Ross Laboratories looking at providing or working with the government for reimbursements of supplements for those patients who cannot afford supplements on a daily basis. What we have worked with the state of Indiana is getting Medicaid reimbursement for Advera, Ensure, any supplement for patients right now through prior authorization. So currently we do have a lot of doctors, and I know here Jill LaFawn has worked with some patients in getting approvals through the PA, and I do have copies of that, examples if you'd like to see that after the meeting tonight. But we are getting reimbursements for those who are on Medicaid for 2 to 3 cans a day of any supplement, and obviously Medicare does pay for supplementations, but majority of the patient population is on Medicaid, and obviously we have worked with the government to get reimbursements for those products. So if you'd like to see that afterwards, just meet with me and I'll be happy to give you some samples.
I just wanted to make one comment in regards to that. I think it's absolutely sinful that we, you have to treat the underlying infection. You can't feed people and not treat their infection. If somebody is sick, you need to treat that with medications. But certainly this is a disease where patients waste, and I think that it's terrible that people do not have access to adequate funds. And I have many patients who make a decision on, well, should I buy a bottle of Tylenol, or should I sit down and buy fruits and vegetables, which are terribly expensive? A carton of OJ is $3, and I have people that cannot afford $3. They cannot afford it. They have maybe a disability check of $300 or $400. They haven't been in the system long enough. We have individuals that are in their 20s and their 30s and they don't have adequate resources. You don't save a lot of money when you're 18 or 19 or 20. You don't have lots of money in reserve. So I see lots of people that have very difficult circumstances, and if they are estranged for any reason from their family or have no really good support network, it is very difficult. It's very difficult, and I think that it's just a sin. I hope that we get some legislators that are looking at this. It needs to be looked at. Excuse me. There was a person right behind you. I'm sorry.
Well, before we get off the topic of weight loss and maintaining weight is something that's possibly useful for people with HIV, you've already used two terms, one of them being weight loss, another one being lean body mass, and the thing that I've come across a lot in readings is maintenance of muscle mass or something.
Right.
What I'd actually read recently is that the important thing is not the maintenance of weight, but the maintenance of muscle mass as a proportion of the weight. And some of the materials that you've provided, I believe, also suggest that. So the idea is, well, this is part of the question I'm asking, is the idea, I'm assuming that the idea that you're, promoting is not just senseless weight gain of, fat, whatever, but in combination with exercise. And I was hoping that if I am correct in thinking that muscle mass rather than just weight is the important thing, could you explain the mechanisms of how a person with HIV's body malfunctions and then starts to attack the muscle mass first? Because I didn't think that that was the case in a normal, healthy person.
Right. The mechanism for the starvation in which a person loses weight loss, let me first address the first question. Lean body mass is the muscle mass component. That's what we are referring to when we talk about muscle mass. And anytime we're looking at weight loss issues, since lean body mass and adipose tissue are both components of weight gain, that is, wanting to sit down and refer to weight loss. I'm sure that most individuals in this room do not have access to skin calipers or are not skilled in how to calculate what their lean body mass is. Most people don't know how to do those types of anthropometric measurements on themselves. And the one indicator that probably everybody in this room has in their home or has had access to is a scale. And so when I refer to weight loss with my patients and looking at that component with my patients, that is an indicator that they can look at. I can make the assumption as a dietitian, if you come into me and say, I've lost weight, I'm assuming that you probably also lost lean body mass. But I will not know that for sure unless I have been doing some consecutive measurements of lean muscle tissue. And we can do that by looking at mid-arm circumference. We also do tricep skin fold. There are several anthropometric measurements that we can look at. Of course, there's also another means. You can do hydrostatic weighing, but that's kind of expensive, and most people don't want to be in a dunk tank and going to get weighed. But anyway, this is to answer your question. I'm not trying to be glib here about that at all. But so when we do talk about maintenance of weight loss or maintaining your weight, we're hoping that you're also maintaining lean muscle mass. In regards to the mechanism, I wish I could tell you, but I don't even know. And I mean, I don't really understand the whole mechanism that is occurring when a person has lean muscle tissue wasting. And I haven't been able to find that well documented in any of the journals. Maybe you have some information in regards to that?
I just wanted to comment that I think what Diane was saying, this has not really been discovered yet in terms of the research, why it is that in AIDS patients there is muscle wasting more than there is fat wasting or loss, as opposed to a person who is in a state of starvation, such as someone who is deliberately losing weight, reducing their intake to the point of, say, emaciation. There is more fat tissue loss than there is lean tissue in this particular situation. So I think the research has a ways to go yet to uncover what it is that's going on here in terms of that particular loss.
And I think, on the other side of that, not oftentimes, but in the hospital, sometimes they will have people on hyperalimentation, and basically what they're finding is, we know that's giving people many thousands of calories and large amounts of protein, and what they're finding is that they actually are laying down a lot of fat and not necessarily lean body mass. So there's some mechanism, some metabolic pathway that they still haven't figured out. What is HIV doing to that pathway? So that's still sort of a mystery. I think along with what Diane said, if anyone is interested in like the anthropometrics of the mid-arm muscle circumference and some of the anthropometrics that we can do, the key to remember on those is that it needs to be done by the same person and then periodically to see what kinds of changes. But basically, they're mostly valid if they're done by the same person, if the same nurse goes to the home and does them periodically. If many different people are doing them, the validity is not quite there.
If I
So
can
that's
add,
something to remember.
excuse me, one other thing about the anthropometrics. It's often, too, important that it's not, the measurements that are taken on these individuals is not gauged against the standards, because oftentimes it's good to look at the person before they started to lose a lot of weight and then after they began to lose more rapidly as the disease progresses. That is a much better indicator of their well-being or what's happening with their body tissue loss, that type of thing, the breakdown, the wasting phase, as opposed to comparing it to a standard. Because it's really not accurate that way, and that may give the person a better opportunity, the professional, to see what is really going on and how much wasting there really is. And oftentimes I think in the doctor's office it's not really identified as much as it should be as far as, is the person losing rapidly or have they lost a significant percent of their body weight in a short period of time, and what can be done to arrest this and to really turn that around.
I think there's just another thing to add too. In the hospital, I've actually watched people eat tremendous amounts of food. We've done calorie counts. People eat what we would say really well and still not gain weight. And so there's a lot that's going on that we still don't know. It's sometimes even difficult for us as dietitians to determine what their actual needs are, because we have these theories for different things, but they're not bearing out. You know, I've kind of seen people in the hospital, actually witness them eat daily, you know, thousands of calories and not gain weight. So there's still a lot we have to learn, and we're now in the process of trying to figure those kind of theories out.
I want to add also that a lot of times the medications that the HIV/AIDS patients are on contribute to the weight loss because the diarrhea that they have, and they just don't have the desire to eat. I mean, every time they put something in their mouth, they're afraid it's going to come out the other end. I mean, they just do not want to eat. And their mouths are sore because of the thrush that they have. So there's just a lot of other factors contributing to their weight loss that I think we have to look at.
I wanted to make sure that I always hated, I took a chemistry class my first year in college, first class I ever had, and I remember the professor spouting off terms that I never understood the nomenclature. It's like I didn't get it because I didn't understand. We used a couple of terms up here, anthropometrics, and as I mentioned, anthropometrics are just how to measure the body, and weight. Getting on a scale is an anthropometric measurement, and I don't know if anybody's ever seen skin calipers. They're like little pinchers, and it's like an instrument that's calibrated to measure in millimeters, and we can sit down and pinch the back of your arm, about the midpoint of your arm, and look at, it's called tricep skin fold, and we can assess a person's percent body fat based on a standard. You know, so we would take your measurement and then do a calculation based on a standard and what your percent of a standard would be. One other term that was used was hyperalimentation. Hyperalimentation is a means of feeding patients. We usually progress to 2 or 3 different means for feeding patients. We have voluntary feeding and we have non-volutional feedings or non-voluntary feeding. Voluntary feeding is eating an oral diet. I bet everybody in this room is eating an oral diet. We can supplement that diet by drinking things like the Advera or making a milkshake or something to that effect. The next progression on, usually when people are not eating well, would start to be looking at some non-voluntary feedings. If I didn't want to do any surgery, not me personally, a surgeon didn't want to do any surgery on you, we'd do a non-voluntary feeding like a nasal gastric tube, where they sit down and they insert a tube in your nose and they go down through the throat into the stomach. We'll feed somebody. I tell you, if you were in a car accident and you didn't want to have your stomach scarred with some type of a surgery, we would do that. There are also some fairly non-invasive means of feedings. We can put a tube in your stomach called a PEG tube, and we can feed you through the stomach that way with the tube feeding. These are really good feedings because we use the GI tract. You know, and you've heard the term use it or lose it. We want to make sure your stomach is being used, and all the small intestine and the large intestine, and of course we know what comes out the other end of the large intestine, you know. That's the end product of our food consumption. But we want to make sure that a person has an opportunity to use as much of the GI tract as they can, because it's a whole system that we have medical science devoted to, gastroenterology, and it's very important that you use that. You know, bodies, individuals that do not use their GI tract, they start to atrophy and become useless, you know, and take a long time to get them back in shape to be used again. The last means of feeding, the hyperalimentation that we were talked about, this would usually be last means of feeding, although I don't use it as a last means of feeding with all of my HIV patients, and I have to be very careful here because people think, because I work for an infusion company, that I really try to push TPN. I do not. I have very few patients that are on TPN, and I usually only recommend it with HIV patients if I know that they're going to have a fairly positive outcome. I like to use it in people that are pretty healthy, and maybe they've had one of their first bouts of losing weight or their second bout, and they're usually somewhat below their ideal body weight. I usually look at 10 or 15%, and if you want to know, I'm getting in all these little tangents, what your ideal body weight is. For men, 106 pounds for the first 5 feet, 6 pounds for every inch thereafter. For women, I'm 5'8". So for women, it's 100 pounds for the first 5 feet, and then 5 pounds for every inch thereafter. And that's a mid-range weight. So I'm 5'8", 140 is my mid-range weight. And we can go up and down from that 10 to 15%. So I could, you know, maybe be up to 165 or maybe about down to 125 would be my ideal body weight range. That's how we determine that. If I have an HIV patient who has had some weight loss, and they've had like their first or second bout of weight loss, I might suggest TPN for those patients. And what that is, hyperalimentation or TPN, is feeding a patient through the vein. We can do it peripherally, or we can sit down through a central line, which many HIV patients have already, to infuse home antibiotics. They insert, anybody in here in science classes? I'm sure this is a healthcare class, but we insert a catheter through a large vein. Usually it's the subclavian vein into the superior vena cava, and we can infuse large amounts of nutrients that way. Mm-hmm.
So specifically, what are the implications of losing lean muscle mass?
Well, when
You've talked some about additional opportunistic infections. However, you know, I know oftentimes I'll have clients who have pretty much wasted away and are in the hospital, and they say, "Can I get my lean muscle mass back?" And I think that's a real important question here, and you know, a point that we want to drive home is, you know, after you lose it, it's real hard.
it is very hard to gain. And the thing that's terribly difficult, if you've ever seen anybody who's lost a lot of weight very quickly, when you lose lean muscle mass, it's not only the thing that's detrimental as a dietitian looking at how your body is processing foods. You not only lose muscles from your triceps and your biceps and all this type of thing, but you're also losing lean muscle tissue from vital organs in the body. And so we want to make sure that a person is eating well, so that they're maintaining optimum function of every major muscle in their body, their heart, and all the other lean muscle tissue they have. The thing that's very bad when I see somebody who loses a lot of weight is that they become unable to perform activities of daily living. And you know, activities of daily living would be everything that you do first thing in the morning. You get out of bed, you walk over to the toilet, you go to the toilet, you brush your teeth, you go and feed yourself, you go to class, you walk around. Those are activities of daily living. And I know people who have had severe amounts of weight loss are very fatigued. They don't want to cook. They don't cook themselves a breakfast because they're like, I am too tired to do that. It's too much energy for me to walk across the room. I can choose to go to the bathroom, or I can choose to defecate on myself, or choose to go sit down and make something. So most people choose to get up and go to the bathroom, and then they go back to bed. So we kind of have this vicious cycle. So I find that people are not able to perform activities of daily living, and I want them to be at home and functioning to their, you know, utmost potential.
And what kinds of things can be done?
What can be done? What we try to do is to prevent lots of weight loss by looking at their diet, and sometimes that doesn't work. Some things that are being done right now, on the West Coast I have colleagues that are looking at use of some anabolic steroids, and I don't know what I think about that yet. I haven't read enough research, but I've seen some use of some steroid therapy. I've also seen, and I think that this is going to be a better way to look at, is possibly use of some exercise. Not exercise to the point of fatiguing yourself and of course burning lots of energy, but exercise to maintain lean muscle tissue. And I encourage my patients to walk. I encourage my patients to do some light chores around their house if they can, to maintain, their muscles. Use it or lose it. Get out there and do it.
Some things that I've seen in patients that I've taken care of is, like, if they have had an opportunistic infection and they're put on Hyperal or TPN, once that's started and they get over that opportunistic infection, then you start adding like the snacks maybe 3 times a day, and slowly building up while you're cutting back on their hyperalimentation. It kind of balances things out. Then you can wean them off of the feeding that you're giving them, and they're over their opportunistic infection, and they're able to eat a little bit more.
I think too we have to look at what people say is I'm eating well. We have to really look at that and see what do they mean. A lot of times people, I'll be talking with them and they in their minds think that they've been eating well, they felt like they've been eating well, doing okay, and then as I listen to it and add up the calories in my head, it's not close. I mean, they have done the best they thought they could, but we can find other ways maybe to add calories, to add protein, like you were saying, add more frequent feedings, look at some of the supplements if we need to, but really assessing their intake and not just saying that they're eating good, but really get down to the numbers and then go from there and try to add some regular food so that, again, that the cost doesn't go up, but trying to keep that lean body mass built up.
Right, and I think that, along that same point of looking at an individual's intake, most of us have been bombarded by popular magazines and the newspaper literature that you need to eat low fat, you need to cut out the cholesterol in your diet, you need to sit down and not have anything with sugar in it. Well, that is like totally opposite of what I do with my HIV patients. You need to cut out fat in your diet and be really low cholesterol diet if you have a cardiac condition. Otherwise, you can have a fair amount of fat in your diet. And in fact, fat is a very good way to add lots of calories. Unless you are diabetic and have HIV disease, you need to have some sugar in your diet. And I am going to sit down and suggest a healthy amount of sugar and suggest that you eat Oreo cookies and maybe a big glass of whole milk as a snack in the evening. Most of us sit down and think, God, why would a dietitian sit down and recommend something like that? But, what am I going to do? Say, well, you need to have 12 baked chickens and 6 loaves of rye bread, for your meal. You can't eat that type of stuff. You have to have something where you can really concentrate the calories. I want you to do the sour cream on the baked potato, and I want you to put cheese on your vegetables, and some of those types of things that the general population thinks, gosh, we can't do that. Yes, you would want to make sure you're doing that. Also, I think something that Ross has available. Ross has an excellent video, if anybody is interested, that talks about some cooking techniques for HIV positive patients, and also some really excellent ideas on how to shop. It's the videotape that
We have
promotes
it
Advera.
available here.
It is excellent. If anybody would be interested in looking at that, you might want to talk to Marcia about that.
And I think, too, along that line, it's real important for family and for friends to understand that concept, too, because oftentimes it's amazing how many people kind of think, well, 3 eggs a week, that's it. No one ever can eat more than that. But again, if friends and family understand that it doesn't matter how many eggs you eat, or the whole milk is fine, that you can add margarine, you can add butter to things to boost up the calories if you tolerate it, that they need the support, because it's almost like going opposite, like you said, of what the popular literature is saying about what is healthy eating. So we have to kind of always keep that in mind, and they certainly need that support. I know that a lot of patients need to hear that from me over and over again, that yes, this is the direction to go, that this is what you need to do.
And I think the key is toleration. If you're tolerating it, there's no use to cut back on the fats, like they mentioned. If you're dealing with an intoleration of certain kinds of foods, higher in fats or higher in sugars, then your dietitian can give you guidance on where you need to head. As far as with Advera, a lot of patients initially are put on Ensure or Sustacal basic nutritional supplements, and what we have found with Advera is that there are some protein sources and fat sources that are more readily digested or more easily digested than some of the normal nutritional supplements out there. So our studies have shown that the lean body mass that we were talking about earlier were better maintained with that type of supplement versus, say, Ensure. We found that the trifold measurements were declining because of the intoleration that they had with Ensure. In addition to the weight, we've seen up to 4 pounds gained in 6 months. So a lot of it's, keep with your current diet as long as you're tolerating it and do get as many calories. But there are some opportunities, like they mentioned, with supplements where if you are having some intoleration with food, they can help you get through that period.
Is anything being done with the, like oxygen, antioxidants? I know for the immune system, I know that we spoke about cancer earlier and how that also is really important, how high the immune system for that. And there are products out there, specifically OGT, oxygen therapy blend of antioxidants that has been shown to help specific cancer patients with their immune systems. Is anything being done with that for AIDS patients? Because that directly improves your immune system.
I'll comment. The question was, is there anything being done currently with antioxidants? Is that primarily what you're asking with regards to AIDS patients or this particular area of study? The latest information that I've been aware of, and anyone can comment on this additionally, I think that where we're at right now is we don't have enough information to really determine whether or not antioxidants are really beneficial for us as isolated substances. They may be beneficial in our foods and other substances that have not yet been recognized to be beneficial to us that haven't been discovered yet. In terms of looking at
I want to clarify, does everybody know what antioxidants are? I mean, I'm sorry, I hate to do this, but I'm kind of getting blank stares. Do you know what antioxidants are? No? Antioxidants are vitamins that they're looking at, certain vitamins that stop free radical formation. And I mean, you can look this up in the chemistry classes that you might be taking, but vitamin C and vitamin E have been found to be quite beneficial. So that's what antioxidants are. I'll go ahead and let you finish.
now that I've lost my train of thought. So.
I'm sorry.
No, that's okay. I'll get it back. And I have lost my train of thought. So anybody else want to comment, then I'll come back if I think of
I
it.
think that this is kind of the new buzzword right now, antioxidants. And there's lots of research. In fact, you have some individuals here. You have a metabolic research laboratory within the university here at IU, and a dietitian who's absolutely excellent. I can't remember her name right now at this point. I know she does some coaching for your athletic teams in terms of your football team, et cetera. But antioxidants are quite popular to be looked at within the athletic arena, and free radical formation. This is your body, whenever you're exposed to something that could be a potential carcinogen, your body every day, when you ingest food, you have the potential to be exposed to something that is potentially carcinogenic or bad for your body. And for a cancer maybe to occur or something, some damage to your body, it has to invade the cell. So you ingest a food that's potentially dangerous or carcinogenic to you. It somehow invades the cell. It must clone itself in the cell and a tumor form, et cetera, for it to be, dangerous to you. And the tumor grows and grows, kind of like that Fabergé commercial, and so on and so on and so on and so on. So you get this large mass of really radical cells going on in the body. What they're looking at with antioxidants is that possibly the intake of certain vitamins like vitamin C and vitamin E, that your body is able to, by the ingestion of these foods at a certain level, is able to prevent potentially dangerous substances from entering cells in your body. I mean, that's the whole basis of what antioxidants are. And it's being kind of looked at right now in a lot of different areas. I mean, like I say, the sports arena is looking at this with individuals, athletes that are injured, and we're looking at it for individuals that say have cancer or that have HIV disease. There's not sufficient research that I have found that say that you should, consume, certain levels. I don't have specific levels of vitamin A or vitamin C. So when people ask me about an antioxidant supplement, a vitamin E or vitamin C supplement, I recommend that they try to look at possibly bumping up their vitamin C or vitamin E intake in their diet. You get 100% of the USRDA for vitamin C from 1/2 cup of orange juice. So if you can sit down and do you still have those little tiny 4-ounce juice cups in the dorm service or maybe in some of your sorority fraternities? You drink 2 of those, you have 200% of the USRDA, and I think that that's one of the best things that you can do for yourself. It's inexpensive, it's cheaper than buying one of those big bags of supplements. In regards to the vitamin E, you can be looking at taking in eggs in your diet. You can look at taking in some fish products. Those would be some suggestions that I would sit down and recommend.
The ones that are actually on the market, not directly from health food wording, I know of, like for vitamin C, I know the percentage of RDA is like 1,666%, I think, which is really high. And so, I mean, it is shown, I have personally had some research about that. I would just encourage the rest of the
Right.
what I've seen that's helped.
But I think that
That's
it's,
worked for Alzheimer's patients.
right. I think it's very important that a physician, since you're looking at medications like that, as a dietitian, I mean, I would be prescribing medications if I sat down and I told somebody, which I can't do, I'm not legally licensed to practice medicine because I don't have that type of a degree. And I can't, they are over-the-counter products and you can obtain them on your own. You don't have to have permission from your physician to take any level of a vitamin supplement. But I think it's dangerous, specifically with fat-soluble vitamins, which vitamin E is. Vitamin C, you're probably going to have the most expensive urine in town, and you'll pee it out, and that'll be the end of it. But I have seen some individuals who take 20,000 times the USRDA, and I have seen some rather bizarre levels of vitamin C level. We've had patients, and they have like something that looks kind of like scurvy. Scurvy is the deficiency that you get with vitamin C deficiency. You know, the British sailors, they called them limeys, and they give them half a lime to suck on as their ration to prevent scurvy from occurring. I've seen people have a very bizarre kind of a rash that looks like little red pen marks all over their body from taking excessive amounts of vitamin C. And I think you can get yourself into trouble. So, as a dietitian and as somebody who doesn't have sufficient literature or resource from my professional organization, the American Dietetic Association, I recommend the USRDA, and your physician could prescribe a therapeutic dose of vitamin C or vitamin E if they were so inclined. And if you did not have a physician that was schooled on that, you may wish to consult another physician that was more schooled, but I would never recommend further than 100% of the USRDA.
And I think, too, one thing we have to remember that the field of nutrition is a fairly young science, and the one thing I think as a dietitian I always come back to is that anytime they've kind of said, well, you need to increase this, a couple of years later we come back to find out if you increase this too much, it might have an effect on something else over here. A classic example is the big push to increase zinc. And they were finding if you push zinc a little too much, you're going to end up having an effect on copper and the absorption and metabolism of copper. And so I think we have to be real careful in nutrition not to push one thing, which we later on might find has made a reaction over here that we hadn't expected. Nutrition is very complicated. There's lots and lots that we don't know about it. And so messing too much with one thing might have a result we're not even thinking might happen later on. So I think it's real important to keep, as Diane said, to keep in balance, not to go overboard on one thing, because right now there is no magic bullet in the way of nutrition.
That's pretty much what I was going to say before. Anybody up there? Nobody up there?
We have a
wants to ask
gentleman up
anything?
here. Go ahead.
Okay, well, this is a totally different subject. But I feel like I have to ask, since it's a panel totally of women. I have a male doctor, and I have been interested in, pursuing, more things having to do with nutrition. And I don't think that he is so keen on that. I'm not thinking of it as a cure, but certainly as something that improves the quality of everyday life and possibly extends life in the ways that you have said. I mean, maintain your weight, whatever. I was wondering if you could answer this question frankly, whether you think it's just a coincidence that all of you are women being in this field, whether it's one of those fields like teaching used to be, like elementary school teaching used to be in the early 20th century, that it's not taken seriously as a discipline, and therefore, you know, the predominantly male medical establishment is keeping this down. So
I'm just curious to what your physician is not doing that you think he should be doing. I mean, when you said that he's not really interested in your nutrition, what kind of things is...
I'm sorry, I shouldn't have said that.
Are you not doing any of these things that we've talked about up here?
No, I am. Yeah.
But you don't feel like he is supporting any of these things that we've talked about up here?
I don't think, my personal feeling is simply that I don't think that he considers them that important.
I think that there is a lot of frustration with physicians, and specifically physicians that work with the HIV population. I would assume that, I can speak for certain physicians that I work with that deal almost exclusively with HIV, infectious disease physicians. And I think that there is some frustration with dealing with issues of nutrition because there are so many other very complex issues that they must deal with a patient. And I think that they forget that this is a very important aspect, that a patient can really take hold of their, control of one aspect. This is something that you can really control your intake and what you're doing. But I think that they're so focused on, the medications that a patient takes, and when to start, say, use of AZT. There was like some controversy in the past, and should we use AZT? Should we use DDC? Should we use DDI? Should we use combo therapy? And I think that there are so many issues that, and I'll be honest, many of the infectious disease physicians that I work with are not really that schooled on nutrition issues. To date, there have not been any really significant, really, really good research studies that have indicated that nutrition is efficacious and that nutrition does provide good results. So I think that they are focusing more on issues that probably are more rewarding, on like, well, I can give you this particular medication and it will prevent pneumocystis, and I can give you this medication. And so they're focusing on things that they really can help you take handle of. In regards to...
Well, that's part of my question. Do you think that there's enough emphasis in medical schools on nutrition?
No, I
I
know.
don't think there's enough time for there to be emphasis on, because it's such a vigorous type program that they're very busy. And I think, like bedside manner, some physicians have bedside manner and some don't, but they don't get that in medical school. So it's just one of those things.
I do too.
If you look at, excuse me, Barb, if you look at the difference between the amount of education that a physician receives on nutrition and the amount of education that a registered dietitian receives, there is a significant difference, very significant difference. A lot of doctors aren't interested because of their knowledge base. They don't have the knowledge base. That's part of it right there.
And I think a good physician, just speaking from experience, really has to take a look at the AIDS patient and use a multidisciplinary approach in having a dietitian consult with him. That's very important. And the infectious disease doctors that I work with at St. Vincent, they rely heavily on their dietitian, and they are not scared to admit that they don't know something. So they refer to the dietitian to help them, overcome some type of problem that they're having. I know all the physicians that I work with, as far as using TPN or the hyperalimentation, the dietitian handles all that, and they just rely on the dietitian to deal with the numbers and the weight.
And one thing to empower you too is that oftentimes if you mentioned, could I see the dietitian or can you refer me to the dietitian, I don't know if I'm overstepping my bounds, but I think almost all the physicians in Bloomington would not hesitate to have their patients referred to us, and we can then set up an ongoing, and particularly Lori, can set up an ongoing situation where you might come back periodically, whatever you set up, if it's monthly or every other month or weekly or whatever, and kind of do some general keeping track of weights and maybe mid-arm circumference or food logs, keeping a diary, doing some concrete things. And that service is available here, and I'm sure it's available in Indianapolis. And oftentimes physicians, I don't think sometimes it's not that they don't care and they don't know, it's also a time factor. If you really sit down with a dietitian, we can do an hour easy. I mean, we can work on talking about food, nutrition, and shopping, and label reading and things. It's easily spend an hour. And physicians don't have that time. They just, it's in, out, they have lots going on, and there's a lot to look at. And so I think to empower you, just ask the physician for a referral to the dietitian, and you and the dietitian can work out some programs. And we as dietitians, if we feel there's some area we're a little gray on, like if you're talking about supplements, or, the patient would start talking about vitamin E, vitamin C, we'll contact the doctor, and maybe as a group, we'll all come up with some kind of recommendation.
Absolutely. And I think also in regards, you were asking the question, I am terribly sorry. I tell you, there is a wonderful male physician or dietitian that works at St. Vincent, Robin, and he's excellent. He's wonderful, and he's delightful, and I think is very effective with our HIV population at St. Vincent. Do you think, you would ask one other question, do you think that because it's a women-dominated field that maybe it's not given the proper respect or maybe looked at as seriously? As we've had Barb mention before, this is a young field, and we discovered one of the last essential amino acids in the 30s. So I think that we will see more headway in this field, and I think we are getting a lot more male researchers that are doing some tissue-specific research as well as women researchers, and I think that we will have more of a headway made in this field. And as I was mentioning early on, with the whole focus of the disease, it's been so much toward the social aspect. In the early 80s, there was a lot of social stigma with individuals who had HIV/AIDS. And I think now we are able to sit down and do some more getting down to the business of this, of treating a chronic illness. And not focusing on social aspects of the disease, but focusing more on issues of what do we need to prevent this particular opportunistic infection from occurring, what do we need to do to keep a person's lean muscle tissue mass at an acceptable level, et cetera. And I think we are getting more toward that level now, 10, 12 years down the line with the disease.
Question back here.
What type of diet are HIV patients restricted to? I mean, like, say, Matthew Johnson, they always say, well, he's on a healthy diet. I mean, what does that mean? Or are we restricted vegetables?
I would say primarily calories, getting enough calories. For him, for example, his activity level is probably quite high. He may have slowed down some, but in order to prevent the onset of a significant weight loss, an adequate amount of calories, and as had been mentioned earlier, not being afraid to use foods that have fat in them and sugar in them, just eating a wide variety of foods, lots of fruits and vegetables, if your gut can tolerate that. Of course, with diarrhea being a very common problem, it may be better to go with a lower fiber diet if things start to get out of hand. But I think variety is very important, making sure that foods are well cooked, such as meats, not eating any raw foods, getting into those issues of food safety with regard to the opportunistic things setting in. So variety is very important.
I would say that you used the word restricted. We tend to not restrict at all unless we have to. That's something we encourage people to eat what they like and really enjoy their food. There are times, though, when there are some secondary problems, especially diarrhea, but oftentimes with mouth problems, as you mentioned, Robin, that we have to make some adjustments. And I still don't like to use the word restriction because it's so negative, but we do have to maybe make some adjustments, give some guidelines to help people control diarrhea or to get some food down but still not irritate the mouth so much. So oftentimes we'll provide guidelines, we'll give suggestions, but we oftentimes hate to use that word restriction because it just puts a kind of a roadblock in the, especially in the attitude, I think, sometimes. So we just try to provide guidelines. And the thing with HIV/AIDS, it's, as you know, chronic disease, and there's different stages. Sometimes people can eat whatever they want, and sometimes there's a certain particular problem. We have to make some adjustments in the food, then back to regular, whatever, the stages are. So it kind of flows. There's changes, different stages, and oftentimes the guidelines we give vary from month to month or year to year.
It's really on an individual basis, I think, because every person responds differently. They have different symptoms, different opportunities to get infection, so it's just on an individual basis.
And individuals, typically when we see adjustments, I love this word, I'm going to be using that instead of restrictions in the diet. Typically, intolerances that we see for HIV/AIDS patients, if I would have to say what thing in the oral diet do I sometimes see that people can't tolerate, and many times one of the first things is lactose, and that's milk products. So we may have individuals who were always able to drink milk or eat ice cream or have cheese and then begin to experience diarrhea with that particular type of item in their diet. So what we would just try to do is to restrict milk. Now, if an individual had a large majority of their calories coming from whole milk, we need to make some serious adjustments in their diet and maybe be emphasizing lots of sugar in the diet and fat if they're tolerating that. And that is another area. I have worked with more than one patient who has just severe diarrhea, and by the time I sit down and do a calculation and look at their diet, I find out that they're going to Bob Evans for sausage, biscuit, gravy breakfast, and they're doing the Whopper and fries for lunch, and then fried fish in the evening. And so their diet's very, very, heavy in fat and may cause some problems. So what we might try to do is to back them off. Maybe not cut out all the fat, but try to sit down and back off, some of the fat in their diet.
I won't be the only person asking questions. I was wondering if you could, you talked about the use of nutritional supplements that are specifically designed for people with HIV and VIRA, and Ensure is designed for patients that can't take normal food. But could you comment on the use of nutritional supplements that you could say buy at GNC that are used by bodybuilders and so forth that contain frequently high levels of protein and carbohydrates, very low fat? They contain a lot of other minerals and vitamins and things like that. And I was wondering how, whether you thought they could save, or whether.
Well, I can remember, just to make a comment, I tell you what, I am inclined to use products where I know that they're coming from a company which has very judicious restrictions in terms of sanitation and cleanliness. And, I am more trustworthy of companies like Mead Johnson or Ross Laboratories or Clintech, or a product that comes from a company, because I know that they have probably got some fairly rigorous standards, in terms of sanitation of their products. I can remember in about the mid-'80s, there was a real push to use a type of amino acid, again, trying to emphasize one specific protein. It was L-tryptophan, and people were taking lots of L-tryptophan and adding this powder to their diet in milkshakes, bodybuilders were, and they resulted in having a very bizarre type of anemia. So I always try to caution people, if you're getting something and it is a good balanced mixed product, it's probably okay. I usually don't have the ability to have somebody call on me, from one of those companies to sit down and say, this is, has this and this and this and this product in it. So I can't always vouch for that. And unless a patient brings it into me, and says, here's the label, do you want to look at that? And I can look at it, and maybe make a decision on it. But I would hate to sit down and just, carte blanche, walk in there and take anything you want off the shelf, because I have seen people have some real serious problems. Like I say, when they try to mix and match their own, going to mix a little bit of L-tryptophan here and a little bit of this and a little bit of that, and I think that's kind of a dangerous thing to do.
I would add to that too, and I think a lot of people don't realize that in our society, our food is regulated and drugs are regulated by the government. But there's a gray area in between called supplements that are not regulated. And so when you go to health food stores, the products in there are not regulated by anybody. And so you could be paying a lot of money for something that it's not, because no one has checked and regulated those products. And so I think as dietitians, we tend to stay with the companies, Ross and Mead Johnson and Clintech and some of the companies we feel comfortable with, again, because they come to us, they have standards, they've done studies, we have some sense that there's some regulation within their company. But they've done studies of things out of health food stores that are supposed to be this, and they've taken them to labs to study, and they're not that, And so I think buyer beware in some of those cases. In fact, you could possibly do yourself some harm. Because if you're trusting those products and not maybe doing some of the other things that the doctor had suggested, you might be setting yourself back a little bit. So that's a little hesitancy, I guess, on our part, but that's kind of where we're at, I think, as dietitians most of the time.
Yeah, I agree with Barb and Diane. Obviously, the restrictions are, they're not very, I guess as far as developing food, there's not a lot of restrictions. Obviously, companies like ourselves have to do a lot of research to validate products, and they do a lot of research on the type of proteins that are digested and the type of fats. So I think you're going to find better results with those type products that have that kind of documentation behind them.
Well, the only thing I have to say in response to what, the issues you raised with regulation, relying upon companies like Ross and
He was Jack in the Box, right, in Seattle.
Is that people who are dealing with a terminal illness are willing to try a lot more experimental and radical things than are going to be necessarily advocated by these companies. And one person, I don't remember who it was, but someone said this on the panel, that you recommended sort of sticking by the RDA regulations for things like vitamin C and vitamin E. Well, there are people that are arguing a lot that you should do 10,000 times the amount of vitamin C.
Right, but there's not really any documentation to show that that's going to help them. And that's probably where education comes in.
Remain at 100. I mean, they're going to die one way or the other.
Sure, but they spend a lot of money in doing things that may not necessarily prove to be beneficial, and the money is going to this as opposed to maybe other things,
No, I understand that some people, if they don't do proper research, they may spend money on something that's totally, not going to do them any good, and could potentially do them harm. But I'm suggesting that, there were people at GNC that were passing around sheets in the last couple months or 6 months, because there was the discussion about the fact that these stores should be regulated. And I'm totally against that. It shouldn't be up to someone else to be telling me that I have to get a prescription to use more than 100, the recommended daily allowance of vitamin C. Now, I don't think that passed anyway, but I just don't, I strongly disagree with some of the things you're saying.
well, there's a reason why that is being done. Do you know what that reason is?
What is?
Are you aware of the reason why these types of things are happening?
I know, as you said, that there have been serious problems in the past.
Harm is being done to people, innocent people who don't know any better, the typical consumer who doesn't have the education to know the difference. And the money is the bottom line for a lot of these places that are promoting products that really aren't doing anything or are potentially doing harm. And that's really why this is being done.
If an uneducated consumer decided that they wanted to eat 8 steaks and 10 bags of potato chips a day, it would do them harm. But we're not regulating that.
Right.
In some sense, we are regulating that because what we do for a living has to do with providing that education to people, and it is available to them. So I think that has to be tempered a little bit because there is information available if the person chooses to obtain it. Some people choose to obtain it from a professional. Some people choose to obtain it from a different source, such as a store that's trying to make money, that type of thing. Because I can tell you right now, we're not making a lot of money off of what we do. We're doing it because we like what we do, but it's not, the money is not our emphasis for doing what we do. Whereas a lot of other places are.
A lot of research before they go shopping at their home.
I would think that if you felt very strongly, and I tell you, I mean, I can empathize, I cannot be in your shoes, and I don't know what I would do. I have a friend who is a physician who is HIV positive, and she indicated to me that she has dabbled in alternative medicine to some extent. And I mean, this is a physician that is schooled in the way that I have been schooled on getting research to back up what you say. And if I tell my patients something, you better darn well believe that I have got some research to back it up, because I'm not going to sit down and just, well, I think you should do this because it sounds good to me. I mean, if I tell you something, I've got some literature somewhere to back it up. We don't progress at a very fast level in nutrition research because, for number one, for individuals that are in a starvation state like HIV patients, we cannot starve people to see what the effect would be. You know, wonder what it would be if we don't give them any level of this. Wonder what would happen if we give them 300,000 times this level. And I would say to you, I mean, understanding that there may be some issues that you might want to try, I would say there are physicians and there are groups that are very supportive of looking at some alternative therapies. And I tell my patients, I don't mind if you want to look at this as long as your physician knows about it and as long as there's not like any ill side effects that are going to happen to you with this. I think you have to look at getting a supportive physician, but again, this gets into something that is, I think, just borders on maybe recommending or practicing medicine, so we don't dare do that. You know, as dietitians, we don't. And what we need to do is to like sit down and for the general population, tell you things that are going to keep the majority of people safe. But I do know many HIV patients that take more than 100% of the USRDA. I know patients whose physicians prescribe 200, 300, 400% of USRDA. But that is their physician knowing all of the other medications and all of the other therapies that they're on, making those recommendations. So you can see where our position is up here, where we just don't dare do that. But there are organizations, and if you would like, I think that there's really a fine Midwestern organization. Unfortunately, it's not in our state. It's in Chicago, and they have a fairly good group that is very friendly toward looking at alternative therapies. And if you are so inclined, I could get you the information for that group if you were interested in pursuing that further.
My point really wasn't to endorse any specific alternative therapy. It was about regulation. I'm not in favor of those things myself, and I'm already aware of where I could find out.
Were there any other questions? Before we go, I want to thank everybody for coming. Thank all our panel members. Some of them are from Indianapolis, so. I want to remind you of a couple other things going on this week. There is a panel discussion on HIV and discrimination on Wednesday night at the IU Law School courtroom. And there's another panel discussion called Living with HIV in Bloomington at Rawls Hall on Thursday, December 1st, which is World AIDS Day. And we'd once again like to thank the panel and thank you all for coming.